When it comes to the pain locality, it is hugely variable. Some patients come to me with pain only in the center of the back. Some would have pain like a band in the lower back. They feel like stiffness in the lower back like a band. Some would feel pain unilaterally over the erector spinae area, and some would have bilaterally. Some would have more pain in the back and slight amount of pain in the buttock. Some would have more amount of pain in the lower back and the thighs and slight bit of pain in the lower back. Some would have extreme pain in one side of the buttock and some pain to the other side, and some would have pain like this and go all the way down to the leg, whereas the other side will be absolutely painless. Some would have little bit pain here, little bit pain here, little bit pain here, and little bit pain over here. It won't be a continuous pain. And some would have absolutely no back pain, but pain will be only in the buttock region. Some will have nothing in the lower back, nothing in the buttock, only in the sides of the thigh. They think it could be an ID band problem, wherein it would be a sciatica pain. Some would have pain, no pain or little bit pain in the lower back, but pain will be on both the sides calf. Some would have pain in the groin, or the pain can travel to the front of the thigh. Hope you understood the varied pain locality in low back pain. That's why no one back pain is equivalent to other back pain. Can you use your pain locality to diagnose the source of the back pain? Because the lower back pain structures are so deep, the pain nature would be of mostly somatic, referral or radicular, which means that though the pain is felt in the buttock or in the side of the back, the pain can still come from the spine itself. For example, if it is a discogenic L4, L5 somatic referral pain, there is no rule that pain will be only here. And in fact, most of the spine pains are not in the spine, they are actually traveling to the buttock. For example, when someone has C5, C6 discogenic pain, the pain won't be there exactly in the C5, C6 junction, rather the pain will be traveling to the traps area, or sometimes if the C5 is involved, then the pain goes to the shoulder. Similarly, if L4, L5 is involved, the pain shall not be always here, the pain will be felt over here. But for the conscious brain, the pain will be felt here, and the conscious brain wants something to be done here, and that's why we physiotherapists, not only we, most of the other healthcare providers are focusing on treating this area as if this is the root cause of the problem, wherein the pain is referred or the pain is radicular from the spine. That's the reason why it is not useful to go only by the pain locality to decide the diagnosis. They are either referred or radicular pain. That means if you go by the locality of the pain, 95% of the time you are giving the treatment in the wrong spot. So instead of treating the locality over here or here or here, because these are all the consequence of what's happening in the back. So the sciatica or the radicular pain are not really a problem in the legs. The problem is in the back. The brain is feeling the pain is here. Every types of back pain is different in terms of pain locality. A L4, L5 disc pain will behave differently compared to L5, S1. It depends upon whether it's disturbing the sinovertebral nerve, or whether it's disturbing the exiting nerve, or it's disturbing the traversing nerve. So that will give you n number of variations in terms of pain locality and pain characteristics. That's why you cannot do a randomized control trial for low back pain. There is no two back pains which are equal. You cannot control people in low back pain. Everybody's life is different, their body type is different, their inflammatory tendency is different, their physical habits are different, their extent of disc bulge, disc herniations, their attitudes and beliefs, they're all different. So I don't believe in any randomized control trial done on low back pain, because it is nearly impossible to do an RCT for low back pain. So what is useful here is pattern recognition, clinical diagnosis, understand the patient's life and his inflammatory tendency, go into the physicality of his life and see what's wrong in his life, and identify the best exercise strategy for his given problem and treat him so that there is some hope of improving the patient. I hope you understood something today about the pain locality and how it is deceiving and deceitful in terms of low back pain.